about how I treat myeloma, and so there are a couple things I want to touch on in this short time. First of all, which patients need treatment, this issue about which are the smolderers that we need to intervene, the issue of supportive care, and then, of course, induction, transplant, maintenance, relapse, and then I'll review how we're doing it at Mayo. So I want to remind people this issue about myeloma-defining events in patients that don't have CRAB criteria is a statistical construct. This isn't a clinical endpoint. This is, well, we think you have a higher risk of developing myeloma. And I want to point out a couple of things that a number of these guidelines, particularly that free light chain ratio, came into being before the routine introduction of PET-CT scanning. So there are quite a few, there's been about 80% of them are going to develop myeloma at 2 years. A high proportion of those, I will guarantee you, if they had had PET-CT scanning, would have been defined as having myeloma been pulled out. So I'm telling you that if you see these patients, you should not reflexively knee-jerk and say, oh, kappa 100, you need treatment tomorrow. If you do a PET-CT and it's negative and the creatinine's normal, it's okay to bring the patient back in a month and see what the light chain did. Now, if it went from 100 to 150 in a month, it's going to be a mistake not to intervene. But there are a number of these patients who have ratios over 100. I've been monitoring for 8 and 10 years. That's particularly true when the involved light chain's 40 and the uninvolved light chain is like 0.1, so you get a ratio of 400. So I want to be very clear that when we talk about myeloma-defining events, this issue about using modern imaging techniques and assessing their risk of developing CAS nephropathy is important in determining truly which patient warrants therapy. Supportive care, most important slide in this deck. And that is that there is about 5% of patients that die during induction therapy. You treat them, they have hypogammaglobulinemia, first exposure to chemo, neutropenic, septic, dead. And so the need for prophylactic antibiotics was well demonstrated in a very large population by the MRC that demonstrated that if you give them 60 days of levofloxacin for just those first 2 months of therapy, the mortality rate is sharply reduced. So prophylactic antibiotic therapy when you start patients with myeloma is really critically important. And I'll just tell you that our policy is not only given levofloxacin, but because of this issue of pneumocystis and high-dose dexamethasone, we're routinely giving them levo and we're giving them cotrimoxazole. Levo 60 days, because obviously I don't want everyone with, Achilles tendon rupture and C. diff colitis. So it's a limited course, but cotrimoxazole goes for a long time, minimum of a year. So that's before therapy begins. You know that they're going to get bortezomib. You need to have them on valacyclovir or acyclovir, and you have to have them on VTE prophylaxis because 6% of patients exposed to an IMiD are going to get a problem that could be peripheral, but could also be central, including bilateral pulmonary emboli. So the supportive care is critical. So what about transplant in eligible patients? You heard about VRD light from Dr. Vidge. It's completely legitimate, but the truth is, for patients over the age of 75, which is getting close to our cutoff for transplant, the use of a doublet, it's probably the only situation where a doublet is legitimate, and that's in the infirm population. Patients who are robust, even intermediate, can tolerate triplet therapy. And as I'll get to, the bottom line for both induction and relapse is 3 drugs is always better than 2. Triplet beats doublet in every trial that's been done. In any case, the first trial, which was a French trial, just looked at Lendex. And you can confirm that Lendex is better than melphalan-prednisone. I haven't used melphalan-prednisone-based therapy in 10 years now. It's only used in Spain as best I can tell. And then continuous RD produces a progression-free survival benefit, but to date does not produce a survival benefit. But for transplant and allergy, old, infirm, multiple comorbidities, doublet's still acceptable. This was also mentioned because this is critical in terms of where are we going with therapy. And VMP, which I'm guessing nobody in the room uses. I certainly don't use it because I don't like using melphalan because it's so myelosuppressive and difficult to manipulate. But the bottom line is daratumumab has such high level of activity that its ability to deepen responses is rather impressive. And so you can kind of guess where things are going to go, that dara for new diagnosis will eventually come. This was also shown by Dr. Vidge. And again, adding DARA improves the progression-free survival. Look, it's a disease that has now a median survival of 8 years, so who knows what the overall survival is going to be. There's 17 different salvage regimens, and so asking for an overall survival signal, I think, is just not fair, because I'll be retired by that time. Maybe even Kyle will be retired by that time, I don't know. But it's important that it's only, I think, fair for progression-free survival. This was also mentioned by Dr. Vidge. This was really the thing that kicked VRD into gear. This was newly diagnosed patients, induction with VRD versus VD. And so, versus RD, excuse me. And again, it brings you the message that triplet is better than doublet for virtually every population. And you can see from this was published in Lancet, that you got, and you were talking more and more about it, you've doubled the CR rate. This trial wasn't designed to look at MRD, negativity, excuse me for using the term, Andy, and stringent CR, but it did double it. And, when they concluded that the safety profile was good, and they really felt that the VRD triplet was the way to go. Of course, so we know triplet's better than doublet, because then the question is, what's the best induction triplet? And that was addressed by IFM 2013, which is a randomized study of VCD and VTD. In Europe, it's very hard to get VRD, so they used VTD versus bortezomib, cyclophosphamide, dexamethasone. The VCD arm had greater hematologic toxicity. No surprise, you're giving them all cyclophosphamide. And as expected, bortezomib, thalidomide, you had higher neuropathy rates. But the truth of the matter is that you had a much higher response rate with VTD than VCD. So in Europe, they continue to use VTD. Based on that, we used to recommend CyBOR-D, which is VCD. Well, we've kicked that because you've got randomized data here to show that IMiD proteasome is better than proteasome alkylator. And of course, no one in this room is using VTD. And so we made the intellectual jump to VRD as the induction therapy. And VRD really causes deep responses, not just the response measured by proteins, but imaging responses. So if you look at PET-CT, because that adds another dimension to this measurement of CR, you can see significantly deeper responses measured by getting PET negativity and elimination of all that uptake compared to VCD. This is the efficacy outcomes between the two, and you can see that PR and VGPR rates were better. And so step one was you need to use a triplet over a doublet. Step two is, well, which triplet? And I think everyone in the room is using VRD, and this is kind of the justification of how we got there. Now, as also mentioned by Dr. Vidge, it's not the only proteasome inhibitor. This issue about neurotoxicity and having to come in every week for an injection is a little bit of a pain. And so these all oral regimens, ixazomib cyclophosphamide dex, ixazomib lenalidomide dex, ixazomib pomalidomide dex, all being investigated in the untreated setting. And you can see here, this was just a comparison of 2 doses of cyclophosphamide with ixazomib in the standard dose of 4 milligrams weekly. And you can actually see that the toxicity was actually substantially greater with the 400 dose, so 300 is what we're currently using. And that just what's coming. This is not today. Don't go home and your next myeloma Monday gets ixazomib cyclophosphamide dex. RVD is still our standard, but alternatives that make it easier for our patient population. If you think about ixazomib lendex, once every 28 days you show up, everything's pills, it really has an advantage. All right, so now we're going to move on to this question of, we've got all these great novel agents. DARA is coming to the front line. Ixazim is on the move. Do you need to expose these patients to transplant? Do you need to put them through a transplant with all these great novel agents? So here's IFM DFCI. Look at the randomization. 8 cycles of RVD followed by maintenance versus 3 RVD, a MEL200 transplant, and 2 cycles of RVD, so that the total duration of therapy is exactly the same in the 2 groups, 8 months, because you figure it's about 3 months before you recover from the MEL transplant to get more RVD. And here's what we see. The median follow-up, the progression to death was substantially lower in the transplant. Read that as time without myeloma. Okay, the survival to date isn't better, but the time you're spending not dealing with the myeloma and the salvage therapies is substantially favorable in the transplanted group, with a significant difference in progression-free survival, both median and at 4 years. And that hazard ratio, 30% reduction in progression, is not trivial. I don't know whether the survival is going to turn out to be better, but this certainly, from a progression-free survival standpoint, suggests transplant superior. What other data is there for transplant? Here's the graphical. Number one, if we talk about MRD and the issue about minimal residual disease negativity predicting for superior outcomes. And again, this is just a demonstration that if you're MRD negative, you do better. You'll please notice, however, that it's not the same as cured. You can see that patients still continue to relapse. We don't know if there's any plateau in that curve, but I think it's fair to say that if the patient achieves MRD negativity, it's a good thing. That doesn't mean you should intensify their therapy to get them there, or that you abandon their maintenance if they're not negative, but it's a good thing if you get there. Well, one thing we can say is that transplant unequivocally increases MRD negativity. Well, who's surprised about that? You just got VRD, so you got 3 different proteasome, image, steroid. You've never seen an alkylating agent, which is incredibly effective in multiple myeloma. So you give a MEL200, why should you be surprised that the response depth improves? This, again, from Antonio Palumbo. This is a direct comparison of a MEL200 transplant versus melphalan, prednisone, lenalidomide. Not the best comparator arm, but it's some of the data. And there are 2 issues here. One, lenalidomide maintenance improved overall survival. That's on the right. But what's on the left? Transplant improved survival. So this issue about, well, we've got great drugs, so you don't need a transplant, that's hope. That's not reality. The data is you get transplanted, and if you don't, in my opinion, it doesn't meet standard of care. Here's the 4-year progression-free survival, transplant versus no transplant. And then here's the how many transplant question. This is a real stickler here. If you follow where I'm going, so I feel that there's enough data to say transplant improves progression-free survival, and in one trial with a poor comparator, improves overall survival. And even in maintained patients, overall survival is better. So if 1 transplant is good, is 2 transplants better? The results here are mixed, and I'm not going to have an answer for you because this is the result here of the European trial that looked at single or double transplant. Here's the problem. Wasn't randomized. It's just that what happens is the Germans put everybody through a double transplant. And the Dutch put people through a single transplant, so there was center dependence. It was selected, not randomized. But when you look at their results, 1 versus 2 transplants overall, not much difference. But if you look in the lower right-hand corner and you look at the high-risk population, 2 transplants outperformed 1 transplant. So if you're in Europe, that's important, because if you're in Europe, maybe you're not getting lenalidomide for induction therapy and your choice of regimens is limited. If that's the circumstance, then a second transplant on high risk improves the outcome. But if you're in the United States, this is from the Stamina trial, 2 transplants didn't improve it. So we have 2 diametrically opposed outcomes, but they were designed differently. Of course, European, it's 4 cycles of VTD, and then you go immediately to transplant. If you haven't had a response, you're off study. Here, you could go on within a year. You could have up to 2 prior treatments. And under those circumstances, in the U.S. trial, no improvement in progression-free or overall survival. And if you look at the subgroup of high risk, no improvement. So I can't answer the question of 1 or 2. In Europe, high risk are getting tandem transplants. In the United States, it's all over the map. There is no evidence basis for which I can answer that question for you. We have differences even within our group. Maintenance therapy. There's no question maintenance therapy improves survival. Meta-analysis looking at lenalidomide maintenance really has shown that in 2 of 3 studies, meta-analyses at galore, survival's improved. But that's not the only thing that's being studied in maintenance. Ixazomib is being studied in maintenance. They did a pooled analysis in newly diagnosed myeloma, non-transplanted. They got ixazomib induction and maintenance. And on maintenance, responses got deeper. Median progression-free survival was favorable. And the number of serious adverse events while you're on maintenance ixazomib was limited. So, ongoing phase 3 trials evaluating ixazomib maintenance in newly diagnosed myeloma, both in transplant eligible, not transplant eligible. One very interesting trial I just have to tell you about is where the patients are getting their transplant, they're registered at transplant, and then they get consolidation post-transplant, ixazomib based, and then they get randomized to len versus ixazomib. I think that's really an interesting trial, although I'm not sure maybe len plus ixazomib is the correct answer for maintenance, and God knows if DARA isn't being studied as maintenance therapy in this patient population as well. Again, the question about triplets better. Which triplet? Is it going to be bortezomib, carfilzomib? You've already seen this slide also from Dr. Vidge looking at carfilzomib, Lendex, and transplant, and consolidation with carfilzomib, Lendex, and then maintenance therapy. And the point of the slide is basically showing how deep the responses get. That with that regimen, single arm, 76% CR, stringent CR. So the possibility of getting really, really deep responses. That doesn't necessarily mean that carfilzomib is better than bortezomib. This is a phase 2, and we've got KRD versus VRD. It's already accrued 1,000 patients. We'll close later this year to answer the question. And then the question is, how good can we do with minimal residual disease? This does come from the University of Chicago group, newly diagnosed. KRD, stem cell transplant, KRD maintenance, stringent CR at 18 cycles, 82%. Wow. That's rather impressive about what can be done with the use of triplet and transplant and consolidation and maintenance. Relapsed refractory myeloma, it's a long thing, but I'm just telling you what I do in my practice. Most of the patients I see, triplet, transplant, len maintenance, 2 years, 3 years, 4 years later, they're relapsing on len. I'll start by telling you what I don't do when they relapse. I don't increase the len dose. That's a waste of time. Having them on maintenance 10 and then moving them to 25 will give you a platelet count of 70,000 and progressive myeloma. It's going to limit it. I don't like that. The salvage rate with doubling up on the len dose is small. So I make a switch. Well, what am I switching to? Well, they're refractory to an IMiD because they're on maintenance. So what I've elected to do based on the CASTOR trial is give them daratumumab, bortezomib, dex. Why bortezomib? Well, they got it as part of their RVD at induction. They haven't seen it in 4 years. There's no reason for me to think that they're resistant to bortezomib, so I elect dara, bortezomib, dex as my personal choice, obviously in the absence of a clinical trial. I'll finish up by going over MSMART, and this is what our consensus is. Transplant ineligible patients. It really doesn't matter what their genetic profile is. Almost everyone's getting VRD, and the real change comes in as to what the maintenance is. Because the trial HOVON study that Dr. Vidge showed demonstrated the value of bortezomib maintenance for minus 17p patients. So we do change up the maintenance therapy for patients who have high-risk genetics. Those patients are getting bortezomib-based maintenance. That's usually once every 2 weeks. For standard patients, we're doing what everyone else does. It's VRD, and then it's RD, and then R maintenance. For transplant eligible patients, which is the overwhelming majority, our age cutoff right now is 77. That doesn't mean that every 77-year-old gets a transplant, but if you look 67, or you look like Andy, we'll transplant you. You know, that's good enough. And what we do there is 4 cycles VRD, collect stem cells. We rarely defer transplant now based on the current data. And then we'll treat them with Len maintenance for a minimum of 2 years because there's no survival proof. Meta-analysis, yes. It's controversial how long the Len maintenance goes on. And then for the high-risk patients, we will use carfilzomib for very high risk, what we refer to now as double hit myeloma, when they have a 414 and a -17 or a 1Q abnormality. Those patients will get carfilzomib-based therapy. Transplant will consider tandem because they have high risk, and then they're going to get a proteasome inhibitor-based maintenance therapy. Final slide, CAR T. Everyone, don't worry, you're not going to be put out of business by CAR T for myeloma, that's for sure. That was updated at ASCO. And the Bluebird, which is the largest trial, was shown. And of course, these are highly refractory patients, and the response rate was incredibly high, but the median progression-free survival was 11.2 months. So that's clearly where we are today with CAR T. A lot of hype, clearly a signal, deep responses, but not durable responses, and it remains to be seen where the CAR T fits in. Thank you.